I'm looking up. Aha, there we go. Great. Thank you. Welcome again. I think we've now had about 10 days of summer this year, so I hope you've really enjoyed each one of them as they has come along. We're going to do our ethics conference a little bit differently today. So I get to do a little bit of the prologue and introductions. For those of you who don't know Dr. Wilfond is the director of the Truman Catt Center for Pediatric Bioethics. He's a member and RMC's professor and chief of the Division of Bioethics. He's also a member of our pulmonary division. He did his pediatric pulmonary and ethics training at the University of Wisconsin. Dr. Walco has joined us as director of the pain service, or pain medicine, in the Department of Anesthesia. He's also a professor of anesthesia. He received his BA from the University of California at Los Angeles, his MA and PhD in clinical psychology, child psychology at Ohio State. Both of them bring to us a conversation today about what are we doing and how are we doing related to the use of placebos. What do placebo trials involve? What do use of placebos in regular care involve? Once again, remember this particular format is they'll do a short presentation and then want interaction with the audience, so please come to the microphone for that. And I think Dr. Wilfond starts.
Thank you, Tom. You can go, for the AV folks, you can go ahead and put the slides up. It's a pleasure to be here. As Tom described, our format is same format, but different players. We're normally, one of our faculty from the Bioethics Center is the moderator, and we ask a local clinician to present a case, and then we actually have an outside speaker who is a national expert in an area talk on the topic. In this case, we did a little differently for a couple reasons. One is that our national expert is already part of our faculty, so that's why Gary Walco will be providing the ethical and the clinical analysis of the issue, and I'll be playing the role of the clinician, presenting the case. But of course, as we typically have, our clinicians will inject some sort of teaching moment. So what I'll be doing is talking briefly about the role of ethical issue of placebos in research, while our main focus will actually be on the role of placebos in clinical practice. Before I get going, one other additional announcement. We have these grand rounds 4 times a year. Once a year in the fall, rather than having a case presentation with a lot of half of the time being spent on interaction with the audience, we do a more traditional grand rounds once a year in the fall. Our speaker for that grand rounds, which will be on October 14th, is Tom Murray. Tom Murray is a very well-known person in bioethics. He's the president of the Hastings Center, and he'll be talking about drugs, sports, and children. So with that as an introduction, let me go ahead and begin our case to get us going. So this is John, and John is a 13-year-old with cystic fibrosis, and he is a fairly typical adolescent with cystic fibrosis. He has slightly diminished lung function. He has an FEV1 of 85%. Now, once a year, he has a pulmonary exacerbation that requires him to be hospitalized. He has other more minor exacerbations that are treated with oral antibiotics. He's in the 7th grade. He lives alone with his mother. His father's not involved in his life. He actually is a smoker, which may surprise you for a person with cystic fibrosis, but there's a less frequency of smoking in CF in the general population, but it's not zero. He also has occasional marijuana use. So this gives you some idea of his sort of character. And then 6 months ago, he had a pneumothorax, which again is a common but infrequent complication of cystic fibrosis. He had a 30% left pneumothorax. This was treated with IV antibiotics and a chest tube. But he had a lot of pain with this, and he was initially on IV morphine and was discharged on PO Percocet. The pain persisted over the next 6 months. Although his spirometry is back at his baseline, his chest radiograph again had returned to normal. His height and weight were back to their normal places. But during that time, he had several visits both to emergency rooms, to CF clinics, as well as to his pediatrician, complaining of chest pain asking for more pain meds. Often these requests were very much generated by the mom speaking on his behalf, saying, my son's in a lot of pain, and we really need to take care of this. And so she also was concerned about, because of this pain, his ability to go to school. And so for the first month after this episode, he was not in school. She felt he was having a lot of pain, and she arranged to have him begin homeschooling. And so over the next 6 months, this process continued. So at the end of the 6 months, he actually is hospitalized again for a new pulmonary exacerbation. He's still complaining of chest pain. During the hospitalization, he's given IV morphine, and at that point, he's not even willing to try PO narcotics. He says the pain is so severe that he really feels like he needs more intensive interventions. The clinical team is concerned, both about what's going on, not really quite sure what's happening with the pain, why he's in pain, what this pain means. Is he really in pain? Is there some sort of secondary gain of him saying he's in pain? It's unclear what's been happening at home and whether he's getting some secondary gain from the pain itself or just being in the hospital. So what's proposed is that the next time he complains of pain, that what we should do is give him an injection of IV saline and see whether there is a response to his pain. And that will be a way of helping to determine what's going on in this issue. So the questions that we'll be addressing, myself and primarily Gary, whether it's ethical to give John this IV saline to determine whether he is in pain, and what are the ethical circumstances that placebos are appropriate to use in clinical practice. But what I'll do for a few moments before Gary takes over is talk briefly about the issue of using placebos in research, because that is a place where there's a lot of experience and a lot of familiarity with using placebos in clinical trials. And what I'd like to do is just spend a few moments presenting a broad overview of the circumstances in which placebos are appropriate in clinical trials in pediatrics, but also point out some circumstances where they may not be appropriate. So why do we use placebos in research? Often it's when we're trying to address questions about the effectiveness of an intervention. And it's a means of trying to minimize both investigator and participant bias when that bias might have a role in determining whether or not that intervention is effective. One of the questions that comes up is it ever ethical to use placebos when an effective therapy is available? And like almost every question in ethics, the answer is it depends. So what I'd like to do is point out a number of circumstances that might be important to deciding when it's appropriate to use a placebo in a clinical trial. First of all, one of the issues would be whether or not, what's the risk in that placebo arm? And the question would be, and so in the circumstance where a person has an active disease and we're intentionally not giving them an intervention that might be helpful, are we posing them at too much risk based upon what's the rubric in the federal regulations, which requires that this be no more than a minor increase over minimal risk? Now that term, a minor increase over minimal risk, we could have a whole hour discussing what that means. So I don't want to get into that right now, but what I want to point out are two examples of circumstances in which, in general, we would be less concerned about a placebo in somebody who when an effective therapy is available. The first would be when the symptoms themselves are mild to moderate. So one of the paradigm examples is allergic rhinitis. So in general, there's a sense that while there's effective therapies for allergic rhinitis, the symptoms of allergic rhinitis in general are not so profound that withholding an active intervention would be posing significant risk to the child. The second has to do with the length of the study. So we could imagine circumstances where withholding, even for a more significant set of symptoms, withholding therapy as long as for a short period of time may also pose less risk than it would be if it was for a longer period of time. So the severity of the symptoms and the duration of the trial are two of the considerations that would have an impact on this. The second thing is really the issues of scientific necessity. There are certain types of conditions in which placebos are really important because either there's a high rate of a placebo response itself, and so we really need to verify whether the response is to the placebo or to the active intervention. Circumstances where there's waxing and waning symptoms in terms of the natural history, so it would be important to know how much of what we're seeing is from the intervention or just from the natural course. And there are circumstances where our effective therapies are not a whole lot better than placebos. And so the difference is very minimal between the two, and that's why we need to sort of sort this out. But there may be some cases where placebos can expose children to excessive and unnecessary risk. And as a pulmonologist, I want to give you a particular example about the question of whether it's acceptable to enroll children in placebo-controlled trials for asthma. In fact, just by a show of hands, how many people think this is a good idea or a bad idea? Who thinks it's a good idea to do this? A few people. Who thinks it's a bad idea? And it depends. That's probably so. But here's what's interesting here. So I need for some background. In 1991, there were guidelines to recommend anti-inflammatory medications for children with more than mild asthma. In 1997, those guidelines were revised to be more specific and recommend inhaled corticosteroids as the anti-inflammatory medication for children with mild persistent asthma or above. So anybody with persistent symptoms was recommended to be on a inhaled corticosteroid. With some colleagues, we did a literature review of 70 studies that were published between 1998 and 2001 that included children to see whether or not they were given placebos or not and what the impact of those placebos were on them. And again, I'm going to be very brief about this because I want to turn this over to Gary in a few moments. But the point here is that when we looked at all of these trials, and we collectively looked at all of the subjects in all these trials and put them together, we found several things. The first thing, if you look on the left-hand side of the slide and look at the number of asthma exacerbations, is that there were more asthma exacerbations in the placebo arm than the active arm. And in addition, there were more individuals who were withdrawn in the placebo arm versus the active arm. What's also interesting is that only 12 of the trials only included children. Most of the trials included both children and adults. And the reason why this is important is that the only justification, the best justification for enrolling children in a placebo-controlled trial and putting them through this risk is that we'll learn information about children specifically that will be helpful for future children. And in the trials that included both adults and children, in fact, in no circumstances were the results for children reported independently. They were lumped with the adults. So it's very difficult to even tell whether there was any actual benefit to the children in those trials. The point of this is really just to illustrate that placebos have a role in research, but there also can be challenges, and it really depends upon the circumstances. At this point, I want to turn this over to Gary, who's going to turn us back over and talk more about the role in clinical care. Here's your...
Thank you, Ben. Thank you, Tom. So the question was, we have this young man who is complaining of persistent pain, and it doesn't seem to make any difference what medications he gets. So the ideas floated of, can we give him a placebo and see what his response is in order to determine if his pain is quote-unquote real. Translation is his pain organic. Whoops, wrong way. So just to define our terms a little bit, the term placebo is one that is at the heart of it here, which comes from the idea I shall please. And a placebo are effects that can be defined as the positive physiological or psychological changes associated with the use of inert medication, sham procedures, etc. The idea here is that, I've got to really learn how to use this thing. When you're using placebo, it's sort of a top-down approach, meaning you give this, it's going to have some effect psychologically, which will then affect the organ system, which will then affect the organ in the cell. Whereas our more traditional medical treatments, it's the exact opposite. It's impacting on a cellular level, which then impacts the organ system, and the person. So we can ask the question, is there a placebo effect that is worthwhile? And a placebo effect would be when you can use placebos beneficially in a therapeutic sense. The other thing I would want to call your attention to is the idea of nocebo, which we could probably have another long grand rounds about. But a nocebo occurs when you give a placebo and there are side effects from that placebo, in which case I want to make it clear that giving a placebo is not necessarily the same as no treatment at all. So it's something that is very, very much worthy of focus. So just to give this some context, we talk a lot about how much autonomy patients and families should have versus how much paternalism there would be in medical practice. So for those of you not familiar with these concepts, paternalism in its purest form would be that the physician understands the situation, intervenes, and doesn't really need little or any input from the patient. You just go do what you're going to do. The other extreme would be models where there's patient autonomy, which is where the patient, or in the case of pediatrics, the family, is calling all the shots. So then the role of the physician is not necessarily to make those decisions, it's to offer information, advise, partner with the family, and work together. So I would argue that if you're using placebo, that would be one of the extremes of paternalism, that you are taking control of the situation, you're not even informing the patient and family of what's going on, so they, at that point, are completely incapable of performing their own risk-benefit analysis for that treatment. So one of the issues that it comes down to, and certainly Ben didn't get into this with research, but it's absolutely critical, if you are going to use placebos in research, there must be informed consent and informed assent that you are going to do that. People have to know that there's a possibility that they're going to be in a condition where they're getting a non-active substance. And so if we do informed consent for treatment, which is what we do these days, where is the role for placebo? How could you possibly go about doing this? So just to frame it a little bit more, so what's the problem with that scenario? What's the problem with going in and taking John, the patient that Ben described, and giving him this saline? So the first is that I would argue that you're not going to get an answer to your question, because we know that there are very real placebo effects. So if you give somebody a placebo and they have known organic disease, they may still benefit or show a reduction in symptoms from that placebo. So even if you're saying to yourself, okay, I'm going to give him this because he's got all of these psychosocial issues going on and we think that's more significant than his pain, so I'm going to give him saline. Let's say the saline works. What have you learned? So will you then go into John's room and say, listen, buddy, you're telling me you've got pain. Well, guess what? We gave you saline and you responded the same way. So your expectation is going to be he's going to sit up in bed and go, darn it, I was caught, there go my symptoms, we're done. Well, that's obviously not going to happen. And it's also not going to happen because you can still, as I'm pointing out, have very real effects. So the problem with it is that if you use placebos unbeknownst to patients and then inform them that you tricked them, you've just completely undermined their trust. They are not going to trust you as a physician ever again because you fooled them. And the bigger concern that I would have is that you might have messed up and used placebos, but now they're not going to trust me, and I'm completely innocent, right? So the idea is it's not just going to be specific to the practitioner who used placebos, that undermining of trust can be generalized. Second is that it's fairly clear that if people are expecting to be partnering in their health care, and that's what we espouse here at Seattle Children's, that we're completely into family-centered care, I would think that if you start manipulating people in systematic ways, that is going to have a negative impact on their satisfaction with care. It's antithetical to sort of the contract that we have. Certainly it lowers the probability that one would seek consultation for their health care decisions. They're going to feel like they're not getting the straight scoop. Concerns about therapeutic adherence. You know, if we violate that trust, will patients then recover and follow with what we want to do? And the last one I threw in is just to be a little bit provocative. I'm not typically provocative in stuff I bring up, but just the idea that who are we benefiting in using placebo in that situation? Are we benefiting John, the patient, or are we benefiting ourselves? Are we somehow saying, we're frustrated, we can't get this kid's pain under control, So we're going to try something else to show that we really do understand the situation and we have some insight even when we don't. So how could you use placebo clinically? Is it a reasonable thing to do? And I think the answer is absolutely yes, you can. But you need to do all of the things that you would do to safeguard and to minimize the negative impacts. So the first thing you need to do is make it collaborative. You have to share in the decision to use placebos. So you're probably sitting there saying to yourself, wait a minute, if you tell somebody you're going to use placebos, don't you blow it, because then they're going to know that you're using placebos and it won't have the desired effect. So if we take somebody like John, I can go into John's room and say, listen, we're having a lot of trouble understanding the best treatments for your pain. And what we'd like to do is give you different medications to try to get your pain under control. Some of those medications may be inert. They may be placebos. Your job is to tell us which of those medications are effective. Our job is to manipulate the medications and understand which one works best for you. Now that is introducing the topic. You're letting the patient and the family know that you're going to be using placebos. And if they agree to it, you can go ahead and do exactly what you want to do. And if you really think that you're going to get that information, you can proceed. So in essence, what you're setting up is an N of 1 trial. You are taking a single subject and you're manipulating different medications to see how they respond. And you're doing that in a responsible way by informing the family and the patient. So given that we're talking about children here, I will throw in a few other caveats. All of the above is certainly perfectly reasonable for adult patients who you partner with, but now you've got a child who's going to be part of this who may not quite grasp all of it. So the first question you need to ask yourself is, what is the child's understanding? What's their understanding of the illness? What's the understanding of the treatments? How do they conceptualize this? And how would using, quote, an inert substance, unquote, enter into the picture? Second, we can get into some of the psychological issues, bless you, of self-concept. What does the child think of him or herself in all of this? How is it affecting them that they are responding to inert substances when in our society that's something that's seen as atypical, that really what you should be responding to are active things? Where's the locus of control here? So we're going to go to the example that Ben gave of a person who's grown up with cystic fibrosis. We talk a lot about health locus of control, who is in control, and certainly if you're a psychologist working with children with chronic illness, you want them to internalize that control, to feel like they can have some mastery over the situation. So if you're throwing in placebos, where does that shine into the picture? And the last is, how does that affect the relationship the child has with their parents and with clinicians? If your parent is saying, sure, you can go ahead and give my child a placebo, what's the message to the child? How do they understand that? Why is mom or dad colluding with the physicians and not believing what I'm saying? So there are cases where we use placebo all the time, and it's okay. So for example, you see a patient, and they come in and they've got some condition, and you evaluate them, and you believe the condition's fairly benign, and you provide a reassuring statement. Like, I've seen a lot of cases like yours, and generally speaking, things blow over in a few days. Is that placebo? Do you know that that's going to happen for that patient? Are you suggesting that that's going to happen for that patient? Are you planting a seed in their head that everything's going to be fine, as opposed to, ooh, this could be serious? So it's how you word it. My daughter's a great example of somebody who, for many years, took advantage of the analgesic properties of Band-Aids, right? So a child falls and they hurt themselves and they want a Band-Aid. You put a Band-Aid on and it stops hurting. Is that placebo? What about using placebos for dose reduction for agents that work? So, for example, it was a little bit of a craze for a while on using placebos to reduce the use of stimulants in children with ADHD. So if you can lower the amount of drug that they're taking and still get the same clinical benefit, just not happen to tell them about that, is that a bad thing? And the last would be what I would call dirty or impure placebos. How often do we go to a physician with viral symptoms and leave with a prescription for antibiotics? So that's not benign. And I would argue that in our society, we expect that. If you go to your doctor and you've got symptoms and you leave with a handful of empty instead of a prescription to go fill it and get the miracle cure for your condition, you're going to feel a little bit shortchanged. And so whether we think about it or not, we kind of invoke placebos all the time. So I've probably convinced you by now, or hopefully got your wheels spinning, that if you're going to use placebos clinically, you really need to do it very thoughtfully, very carefully, with a great deal of planning. That's the placebo gods. You got to do it with a great deal of planning and really go into it with your eyes open. So hopefully you're there with me. And now I'm going to throw a wrench into the whole thing. So this is actually, I have to take my hat off to my colleagues in GI. A couple of months ago, they had a journal club where they looked at different treatments for chronic abdominal pain. And this was one of the papers that was presented at that journal club, and I just want to take a couple of moments and walk you through it. The question is amitriptyline a beneficial drug for treating chronic abdominal pain? And so this was a large, multi-center, collaborative trial where patients were randomly assigned to get amitriptyline or placebo. Just to address Ben's issues, I would argue that there truly is equipoise here. I have absolutely no problem with this study because the available data on amitriptyline for chronic abdominal pain are largely absent. So if you really don't know whether there's a benefit or not to using amitriptyline over placebo, it is reasonable to use that as a paradigm for a clinical trial. So here's what these authors found. Of the children who got amitriptyline, 59% felt better, 4% felt worse, 15% said that their pain relief was excellent, 35% said it was good, and 3 dropped out of the study due to adverse events. Now look at the placebo. 53% of the children who got placebo said they felt better, 2% worse. 7% thought their pain relief was excellent, 38% thought it was good, and 1 discontinued the study because of dizziness. That may be, for example, the nocebo effect. The number needed to treat was 19. And for those of you who aren't familiar with that, that's the number of people who need to walk in the door for whom you give this treatment before it works once. So 19 is a number needed to treat, I would argue, is pathetic. There's absolutely no significant difference between the groups statistically. I think P of 0.85 is about as close to 0 as you can get. And that for basically all of the patients in this study, pain reports improved pretty much across the board. So if we look at this graph, this is showing amitriptyline versus placebo for pain. So here's my first question to you. Is the use of amitriptyline justified? Given that it's really not significantly different than placebo, and it does have known side effects, like cardiac arrhythmias, for example, sedation, etc., is it justified to use amitriptyline for abdominal pain? The second provocative question is, given that there's no real difference between placebo and amitriptyline, and given that placebo would have some nocebo effects, but nowhere near the same side effect profile as amitriptyline, is the use of placebo for chronic abdominal pain justified? And how do we conduct this risk-benefit analysis between giving a drug that can have toxic effects versus tricking people by giving them placebos? So what Ben and I agreed to do was he was going to go for about 15 minutes, I was going to go for about 15 minutes, and then you guys are going to go for the rest of the time and kick around these issues. So we've upheld our end of the bargain. Batter up.
So again, we'll come to the microphones because that way we'll have an idea of who else wants to talk. So I think we should maybe open it up by saying, given Gary's question, what do you think about the use of amitriptyline for abdominal pain based upon this study? Is that-
Because it's hard to, without
Yeah,
that,
I'm
you
not
don't know
sure-
what the natural history of the disease is. Because if they get better on their own without any pills, then you don't need to resort to either.
So I think it would be safe to say that the natural course for chronic abdominal pain untreated is that it would more often than not continue. It's not the kind of syndrome that generally winds itself out, but your point's a good one, that you would need a no treatment arm at all so that you could see what happens over that same period of time. But that takes the fun out of it, given the available data. So,
Well, while we're waiting for more people to come to the mics, Gary, I'll ask you a question. So it seems like what makes it challenging with amitriptyline is precisely the fact that the side effects can be quite significant, risk of overdose, things like that. What if the same results were found with a drug that had a much more benign side effect profile? I'm curious whether you think that would be a relevant consideration.
so I can answer that in two ways. One is it goes down to number 3 on here, which is the risk-benefit analysis. So if you're going with a drug that essentially you're using, well, I'm going to be bold and say you're using that drug principally for its placebo effect. So if it's fairly benign and you think it's going to have therapeutic benefit, one could entertain using it. Notice that I'm hedging. Because the reason I'm hedging is the way that I prefer to approach this with patients is to give them the data and to tell them, we can give you this drug. The data would show that this drug works in about 22% of the cases. These are the side effects. Let's talk about whether or not you would want to go there. And I would even do that with the more benign version of amitriptyline that you're laying out. I'd probably do the same thing. I would want them to understand where the value is and where it isn't.
But would you explain that the benefit is a placebo effect, or just suggest that it's a real effect? So let's say, for example, the drug I was proposing to use was Maalox. You know, and I might want to say, well, look, this will help your pain go away. We've used this before. This will resolve it. And we don't go into the mechanism of how Maalox reduces abdominal pain in this circumstance.
The question is, are you relying on any data whatsoever to show that Maalox is beneficial? So if Maalox was in a clinical trial and was shown to be as good as some other agent, or these kinds of data, but we'll just substitute Maalox, are you being dishonest with the family to tell them it was used in a clinical trial? I mean, how many drugs do we use where we truly understand the mechanism, right? So then you're going to get into sort of the slippery slope issue of how much mechanism do you need to understand before you're convinced it's not placebo. I mean, if I would love to have this discussion in a psychiatry grand rounds, because if you look at many of the clinical trials for psychotropic medications, the difference between the active drug and placebo is not very big. So I think we have entire fields of endeavor where we're on that slippery slope.
Yep.
Speaking of not understanding mechanisms, from the rheumatologist's viewpoint, when we had placebo arms for arthritis studies, there was always a 30% placebo response, and it was very puzzling. What it means to me is, I mean, all drugs have potential side effects, so I don't think we should ever use a drug for a placebo effect. But what it means to me is there are these huge placebo effects that even have effects on joint erosions. And we need to concentrate on those and try to figure out how to capture those and affect those without giving pills, which is what you do, I know, for much of your work.
The hard part in doing that, and I think your point's a great one, and there's a huge literature on what goes on with placebo. What I didn't get into with John and the case that Ben laid out is I would argue the entire conceptualization of that case is not correct. That the idea of dichotomizing pain as being purely physiological or purely psychological and somehow treating one or the other is passé. And I think that if you sort of move over into placebo with that same mindset of saying either drugs have a real biochemical physiologic effect or they have a psychologic placebo effect, if you move away from that and get a little bit more integrative and use that as a model, your concept is spot on The question is the field ready for that?
I think when I think about is the use of placebo justified, I come down to this question about, I think there's two ways this might play out. One is the use of placebo, or does it require that there be a deception? So in other words, I have to give them something that they think has an active ingredient in order for them to have the placebo effect actually play out in the clinical benefit. And if that's true, then that creates this ethical dilemma because you really are pitting the patient's autonomy versus the beneficence. And that's really, that's a pretty tight Gordian knot to really try to unwind. On the other hand, if you can sort of disengage those two and say that there are, there's a way to get the placebo effect, like the Band-Aid effect, where we're not really employing deception, but we're somehow using reassurance or some other mechanism, and I guess that comes to this question about, well, what exactly is a placebo, and exactly in each clinical scenario, how are we going to parse out whether or not it is required that we use a deception or not?
Well, don't leave the microphone yet. And your suggestion would be?
Well, I think if you have a trial, again, where you say we try reassurance versus a pill, that's just sugar, versus an active ingredient, then you could have, then you know that versus nothing, like a four-arm trial, right? With 5 hours. So that would be the ideal to really know whether or not it's I think the way you can get around this, I suppose, is you try the non-deceptive placebo, and in clinical practice, I think that's something we do all the time.
So you're okay with it? So you're okay with it?
I'm okay with reassuring that whole idea that I've seen this before, it seems to go away, and giving people reassurance. I think that's going to potentially have a placebo effect.
I have a question for Glenn. Glenn, what do you think about the Band-Aid for the abdominal pain?
Well, I've bought warts from kids. The whole idea of 25 cents. And, or you give them 25 cents. Or so I give them 25 cents if I'm buying this wart. So that means they can come back and ask me on. A lot of people try that, right? And, so I don't have any big trouble with using some occasional with kids, suggestive things. You're hoping that you get a placebo effect, something that's. And again, I think there are placebos that are completely benign. So, like candies.
Great.
Yeah.
So I can see that a Band-Aid might not work quite so well on your 15-year-old with chronic abdominal pain. But what about alternative remedies that you suspect may be primarily working because of their placebo effect, but that the parents are really bought into? How do you approach that? I usually say, if it's working, that's great. We don't know how it works, but if it's working for you, that's just fine. But I sometimes feel that's a little cowardly.
We never encounter that in the pain medicine clinic. So the response that I have is not dissimilar to yours, and that is if there are data, then I have no problem talking about the data that I know. Most of those treatments tend to be benign, although not regulated, and you don't really know. There are some data to show that some of them are not benign. So, for example, chiropractic manipulations in an adolescent for back and neck pain may not be benign, and so I, again, if there are data, am comfortable going there. And it's kind of a balancing act because I don't want to take away their hope, and if something's working, great. On the other hand, I feel like I'm not being honest if I'm party to that and either tacitly or explicitly endorsing it. So it's kind of a, yeah.
I don't recall whether all possible reasonable causes of abdominal pain were eliminated from these studies. I also wonder why the alternative medicine people were not involved in such studies. There, of course, naturopathic medicine, I believe, is well known for its prescription of treatments which many others in Western medicine feel are placebos. And to give you an example of this, it happened in a relative of mine who had abdominal pain, was told to take Maalox, which had no effect. He read something in naturopathic medicine, take a teaspoon of apple cider vinegar, and his abdominal pain was eliminated immediately. And the rationale for that was that his stomach was not producing enough acid. So if you take vinegar, you get enough acid. Anyway, but the whole point of alternative medicine in evaluating placebos.
So, a couple of comments. One is, it would make my heart soar, S-O-A-R, if there were good quality placebo-controlled trials for a lot of the complementary and integrative strategies. I think, for example, the acupuncturists have done a nice job with that. I would argue that if you're talking about things like hypnosis and imagery, which used to be considered complementary and integrative, that's mainstream at this point. And when we did this journal club with the GI people, of the 3 papers we looked at, the most promising was cognitive behavioral and hypnosis for treating that kind of pain. So in my mind, the data are what we want, and having better controlled trials would be great. And things like peppermint oil has been shown to be beneficial for some kids with abdominal pain. So I don't think it's out of the question. We just need the data.
Get back to ADHD. We had the pharmacy at University Hospital develop capsules that will enclose both the stimulant and a placebo, and we would ask parents when they came in for evaluation, and very often sent in by the school to receive treatment, if they would be willing to use a placebo trial where we would give them a set of pills and they wouldn't know which ones were the stimulant, which ones weren't. The point is that about half the parents refused to do this. What do you do then in terms of trying to set up a placebo trial?
Hit it out of the park.
Sure. Well, I think there, first of all, it's important. That demonstrates precisely why it's important to have that conversation with them up front, because if they would be interpreting that in such a way where they were to find that out later and have that view, it would be really problematic for your long-term relationship with them. So that, I think, underscores precisely why it's important to do it in the first place. I think, though, that then you need to have a conversation with them about why the concern for their refusal is, understanding more about what their worry is about that idea, and then hopefully try to understand where they're coming from, and then continue to work with them and approach it. I think it would depend on what the reasons were.
Good morning. Gary, I totally applaud the fact that you address the concept of separating the physiologic and the organic pain and addressing it as a whole. And essentially those who deal in hypnotherapy kind of take that concept on. What I'm fascinated in is that in this whole discussion, one word has not been used: hope. And so I would like you to address that word and the literature on hope and how that plays into things like this. If you, not, I know it'll probably take a whole day, but if you would mind just addressing it in a short way.
So
Is that hopeless or hopeful?
I'm hoping something comes. No. Clearly, hope is critical to coping, especially with more recurrent and chronic conditions. And I think if I were to sum up the literature from, say, the pediatric oncology studies, it would be that you want sort of an optimal blend of hopefulness and enough reality that people understand what's going on and comply. I think the issue of hope is intimately tied into the relationship between the patient and the physician, or the parents and the physician. And for the purposes of this talk, I think that part of where I'm coming from with eroding that trust relationship would be all of the sort of reverberations and ramifications that would come with that, and to address your question, including what that does to that hopefulness, that the person who I have this relationship with, who's caring for me, is not being honest with me.
Can I add something to that?
Feel free.
I think that one of the other ways of addressing your question is clarifying the object of the hope, and sometimes redirecting the object of the hope. So, you know, again, if we imagine a child with CF who's sicker than the one we described, who's having, you know, multiple pulmonary exacerbations a year, it may not be realistic to hope that those will completely go away. But yet we may be able to redirect their hope in a certain way of what they can be hopeful for given their circumstances. And so I think that's the other way that notion of hope is still relevant regardless of the circumstances, by coming up with realistic things that people can hope for and have aspirations for.
Can I have Beth go first?
From the developmental peds world, we saw a very similar pattern in placebo-controlled trials with the use of IV secretin for decreasing symptoms of autism. And when the families, this kind of gets back to families refusing placebo and perhaps hope, when the families were presented with this data, they said, we don't care, we want the secretin anyways. And I think some of this is related to the fact that as a culture, we still associate placebo with sham, and that sham has a negative attribution, and that we have a long way to go as a culture in understanding both the physiological and the psychological effects of pain or symptoms.
I couldn't agree more.
So perhaps the extension of that is, where are we now? And I'm going to bring us back to our patient who has chest pain. There is a study about a year and a half ago looking at folks who have knee pain. It was in adults. The standard of care was, in fact, to do endoscopy, remove bad humors from the knee, and that was going to make the knee pain better. And this is in the Scanier method, so you look at then those folks who had the wrong knee scoped, and this really, it particularly likes, Dr. Fisher likes those cases. And lo and behold, their outcomes were exactly the same. And the challenge was to put together a study that had a surgery, a harm, a hole made in the skin, and look at the outcome. So there is one piece. The other piece is, we just recently have had a big flare of information about one of our new magical drugs, bevacizumab. Avastin has been used in adults with lung cancer and in adults with breast cancer. And lo and behold, we finally got to that comparative trial, and its benefit in breast cancer is minimal, but its expense is huge. So I would have you back to, we're all faced intermittently, and I liked your example, my third point, of what do we do with antibiotics and otitis media. We're all faced with these instances where we're trying to deal with the patient, the N of 1, and that patient may or may not want to participate in an N of 1 trial. So what are we doing with that? How do we as a culture begin to say, we don't know what we're doing here, and we're going to give you something that we think is pretty benign, but we're going to give you Augmentin. Oh, we're increasing the resistance to that antibiotic. Those are the challenges.
So I'll yield to Ben in one sec, but I think that there are some huge forces in our society in particular that work against that. We are one of the few countries on the planet that allow drug companies to advertise directly to the public the benefits of their drugs. So if you sit and watch television, you'll see one commercial after the other for this product that has overwhelmingly great results. I kind of laugh because when you really watch those commercials, at least half of the commercial is the disclaimer with all the side effects that they kind of mumble at the end. But it really plants the idea in people's heads that go talk to your doctor. This is a drug that can do wonders for you. And I know it hit home with me when Lyrica came out for fibromyalgia because their data are just not that amazing, yet all of a sudden everybody wants it for their pain. So I think that's one force, and the other is that we perpetuate that. I think that we feel like we need to deliver goods, and that if a patient comes in and we don't give them something concrete and something that they can take home and hang their hat on and feel like they got something worthwhile out of seeing the doctor today, we're not doing our job, even if that's not the case.
Yeah, I certainly agree with everything that Gary said. Tom, I thought you did a nice job of laying out a number of particular considerations, which include cost and risk, as well as risk to others or harm to society. I think what's challenging, a couple of things are challenging. One is that those calculations work out differently if you're looking at the population context. Should arthroscopy be reimbursed by insurance for treatment of knee pain? You know, is different from the decision whether an individual patient should have that. So I think, and because they may look at those combinations and those balances differently. I actually want to make one specific comment regarding the studies about the arthroscopy, which was, again, those were done for clarification, those were done in a research context. People who participated did agree to give their informed consent. The challenge was whether there was could it be justified to put people under the risk of the anesthesia, knowing that there was no possibility of benefit. And when they went through that analysis, what they came up with is that, yes, there was some risk of that, but they also acknowledged that there was also sufficiently unclear evidence that the arthroscopy itself was beneficial either. So in a sense, the risk was plausibly the same in both. And because of the other evidence they had of people benefiting without having it done or having it done on the wrong knee, that led them to believe that these were so similarly positioned that it was still justified to do that sort of research. And the impact of that has had huge impacts on clinical practice.
Gary and Ben, this has been a great discussion. I have several questions actually, and one relates to whether the condition is acute or chronic. Being a grandparent now, I have the little iced rabbit for every little bump that comes up that we pull out, and the Band-Aids with all kinds of, and so we use that all the time. But if a placebo in a study is found to be effective or more effective, is it then in the future a placebo, or is it a therapy? Secondly, in chronic conditions like this, I find this very unconvincing. Without stopping it, seeing if the condition comes back, trying it again, because I have a hard time separating out the idea of placebo versus any intervention, based somewhat on this hope. And there's, to Maggie's point, a wonderful book by Jerome Groopman called The Anatomy of Hope, which is an incredible book. And in that book, it describes it defines hope as arriving at a better place. So I'm curious about the concept of, in a chronic condition, can you really assume that there will be a long-standing effect? Because many times, the commitment to a therapy, when it's stopped, and if the condition comes back, it may be different. So I'm a little curious about the chronicity and can you really rely on one study in a chronic condition without stopping it and trying it back? And then secondly, what's the difference between a placebo and an intervention of any kind?
So I'm going to try to play around with your second question first, and that is the difference between placebo and intervention. And I think there's obviously not a clear answer. And whenever we think we understand the specific mechanism of what we're doing, you look back at the literature from 20 years ago at what was believed to be the truth for various interventions, and now we go, well, what were we thinking? It's just completely ridiculous. So I think it's extremely relative, and in my mind, the way I sleep at night is basing it on what the data would show. And sometimes we use interventions because they work and we don't know how or why they work. And sometimes it's the other way around, where you'll have certain discoveries about a given mechanism, and then you come up with a drug to affect that mechanism, and it develops that way. But I think, if I'm understanding how you pose the question correctly, you can't answer that. It's relative. It changes with time. It changes with circumstance. And in part of it for me, Bruder, is what's your intent? And how are you using this? Are you using this because you genuinely believe it is an agent that can bring about change, or are you using it to trick the patient because you want to differentiate where they're at in the example that Ben gave?
Okay, and similar to what Al, there was a paper last, and I apologize because I didn't read it to the methodology adequately to describe it, but it was a study with ADHD, and the placebo was described as a dose extender, and it allowed them to reduce the dosages of the stimulants, and so the question is it then a therapy? I mean, in terms of it really worked in that study, and it was a convincing study. So then, is it a placebo? It may be inert, but if you say this, we have found this, it allows a dose of stimulant, lower dose of stimulant, to have a greater effect, and it does do that. Is it still a placebo?
So it goes back to me to what you said to the family, because if the family says, oh, so you've been giving my kid sucrose as a treatment for ADHD, and why are you messing around with me that way? And if you don't tell them what the rationale is, what the data show, etc., I think that's the risk that you run in terms of that trusting relationship. And you can also make the argument to say, there's some amazing data to show that using a little bit of sucrose with Ritalin reduces the need for Ritalin. Yeah. So
I think that's probably a good way for us to end. We're now at 9 o'clock. Unless you have any final comments, Gary?
no, the chronicity piece we could go with for like hours. Thank you.
Thank you. It takes a little while for people to get going. To bed it's
Yeah. I'll sneak that out of your hands.
Thank you.
Isn't it challenging? So what would you have done? I wanted to thank you for